Medurstand. Understanding Medicine.
I am Professor Azizur Rahman, and after completing a module on ischemic heart disease, let's have a quiz. If you have attended my earlier lectures, we covered risk factors and prevention of ischemic heart disease and the overall burden of ischemic heart disease. We discussed angina pectoris in detail, symptomatology and the investigation and the treatment principles. We had a separate lecture on acute coronary syndrome where an approach to patient with acute chest pain was discussed and a differential diagnosis was built on the basis of TROP-T and ECG. And then we had a lecture on ECG localization of myocardial infarction. Now this one is actually a repetition of the same but in the form of quiz. This will of course not cover the entire contents, but let's have some revision, and there will be some points which will require some discussion. Others we will just pass through. Or let's have the quiz. This is the first question. In patient with dyslipidemia, uh, previously we used to call it hyperlipidemia. You may still call it hyperlipidemia, but dyslipidemia is a better term. In patients with dyslipidemia, which one of the following is usually the target of our treatment? Lipid profile consists of total cholesterol, triglycerides, LDL cholesterol, VLDL cholesterol, HDL cholesterol, non-HDL cholesterol. In fact, it is further expanding. But of the five listed here, total lipids, triglyceride, total cholesterol, LDL-C, and HDL-C, which in your opinion is usually our goal of treatment. So which one we want to correct? Of course, others will also be corrected with the same therapy, but what is the goal? Most guidelines they will address LDL cholesterol because we know LDL, especially the small dense particles, the atherogenic particles, they are most closely linked with atherosclerosis. So LDL is our usual target. Of course, we want that total lipids are also reduced, triglycerides are also reduced, total cholesterol is reduced, and we also hope that HDL is increased and non-HDL cholesterol is also reduced, but our primary aim is LDL-C. So if one achieves an LDL-C goal, that means the job is done. So let's have another question now. What is the goal LDL-C in following groups? I have listed 4 groups and we will take them up one by one. Let's first take up this diabetic patients. That means they have dyslipidemia and they have diabetes. Uh, because it is not mentioned here, that means they do not have any other comorbidities, just diabetes. Which you think should be the goal? And this is given in milligrams, 160, 130, 100, and 70. Below which you think should be the goal in diabetic patients? Well, according to the guidelines in a diabetic patient, LDL-C should be less than 100 milligram per deciliter. Okay, so I think that should be the aim. Uh, Many would argue that in diabetic patient, irrespective of the baseline lipids, one should be given statins. If you believe in that statement, you could give statin to all diabetic patients, but at least you should have this LDL-C of less than 100 if their LDL-C is higher than this before starting treatment. What about post PCI? Somebody already had a coronary event, or somebody was discovered to have coronary artery disease without having an event, but underwent post this percutaneous coronary intervention. What should be the goal in this patient? Patient has dyslipidemia and has just undergone a PCI, percutaneous coronary intervention. Which of the 4 values is the target in this group of patients? Yes, less than 70, because the chances of having a coronary event is the maximum if you already had one. So we are now dealing with a high risk group. So the recommended LDL-C is less than 70, and this kind of LDL-C cannot be achieved without the use of statins. Even in diabetic patients, I don't really think that dietary restriction can achieve LDL-C of less than 100. Similarly, less than 70 will be impossible to achieve without the use of statins. So we should use statins in post-PCI patients to achieve LDL-C of less than 70. And the next category is no comorbidities. Well, now we have a group of patients with dyslipidemia but no comorbidities. That means they do not have ischemic heart disease, and they do not have diabetes, and they do not have any other risk factor, like let's assume they're not even smoker. Just incidentally they have been discovered to have dyslipidemia. Maybe they have a family history of ischemic heart disease, but they do not have any other comorbidity other than dyslipidemia. What should be the goal in this group? Well, in these patients, if you can maintain LDL-C less than 130, that is good enough. Perhaps this can be achieved with lifestyle modification. You all know that main source of cholesterol in our blood is the liver, not the food intake. So, if these patients have very high cholesterol, say for example, LDL is 200, 180, then perhaps they would need statins. But if their LDL-C is like 150, 160, maybe with lifestyle changes they can achieve less than 130. And the last group, patients who have not only suffered from coronary artery disease, maybe they had suffered from multiple times, they had multiple events, they had also uh, undergone PCI or cabbage, and then they have further complications of ischemic heart disease like heart failure. So these are actually very high risk group. This is relatively recently defined group, very high risk group. I think you should be able to figure out if this is a very high risk patient, then you should uh, try to achieve A1C of less than 55. Now, of course, this would be difficult to achieve, but possible. Many patients would, at least 50% patient may be able to achieve this kind of LDL-C with high dose, high intensity statins like rosuvastatin 40 milligram, atorvastatin 80 milligram, uh, and some would need PCSK9 inhibitors also. We do not have PCSK9 inhibitors in our countries yet, but we should at least use high intensity statins. We need to try to achieve these goals, and if somebody does not achieve the goal, it is not like he has missed the train or missed the flight. He has still achieved. Somebody we're trying to achieve A1C of 55, and that person has achieved 60, he is still very close to the goal. I think that person also needs to be appreciated for his effort and will benefit. Now, this is the summary actually, what we discussed. LDL goal in people who have this, the order is not different. Those people who have no comorbidities, just dyslipidemia, the goal is less than 130. And in diabetic patient, it is less than 100. And in post PCI, it is less than 70. And patient with ischemic heart disease and further complication like heart failure or chronic kidney disease, then it is less than 55. And please note down that these are milligrams per deciliter. And the other thing is that you need to keep it below this level all the time. So once a goal is achieved, then the treatment must be continued. Uh, Between 130 in this group, between 130 and 160 is actually called borderline dyslipidemia. Maybe you can try with lifestyle changes alone. But in all the other groups, I strongly recommend that you need to use statins, because without statin, this tight LDL control is not possible. Uh, which One is not the correct statement regarding acute coronary syndrome. So you have to identify just one statement which is not correct, assuming that all others are correct. A normal ECG rules out acute coronary syndrome. A positive troponin test 5 hours after the onset of chest pain confirms myocardial infarction. A positive troponin test 7 days after the acute coronary syndrome may not indicate recurrence of infarction. A normal ECG and negative troponin test suggest the diagnosis of unstable angina. Which one is not? We are looking for the statement which is not correct. A normal ECG rules out acute coronary syndrome. This is not correct statement because in unstable angina, a patient may have critical coronary artery disease, but ECG may be just normal. So this statement is not correct. All others are correct. For example, 5 hours after acute MI, troponins are always positive. Positive troponin test 7 days after acute coronary syndrome may not indicate recurrence of infarction because troponins may remain positive for up to 2 weeks because of the first infarction. Somebody had infarction, troponin level is high and that keeps on declining but may remain detectable till 2 weeks. So if you do this test 7 days after the first attack, it may or may not indicate a recurrence infarction. If you're doing quantitative assay and if there is further elevation after 7 days, then of course that could mean recurrence infarction. Uh, then normal ECG and negative troponin suggests the diagnosis of unstable angina out of acute coronary syndrome. That's right. A 60 years old male calls you and describes typical chest pain for the last 1 hour, typical of ischemic heart disease. And what will you advise him on the phone? Take diclofenac sodium 100 milligram and take rest. Take omeprazole 40 milligram with milk. Take 300 milligram of soluble aspirin and go to the emergency. Don't worry and go to sleep. Go to sleep. Which you think is the correct response in a 60 years old person who you haven't examined, but on history on phone he gives you history which is quite suggestive of ischemic heart disease. Or rush to the hospital where cardiology services are available. That is another option. Which you think option is most doable and the best? I would take this 300 milligram of soluble aspirin and go to the emergency of any hospital. You know why aspirin? Although it is recommended that aspirin and clopidogrel both should be taken as the first loading dose, 300 milligram of each, but this patient may be living in some remote area. I believe aspirin should be available and clopidogrel may not be available. In any case, there was no option in the question of clopidogrel with aspirin. Out of the option, I think 300 milligram of soluble aspirin is the best response. Why not the last one, rush to the hospital where cardiology services are available? Because in our country, these hospitals are only very few where cardiology services are available. So that will be like waste of time. I think it would be best if this patient goes to the nearest available health facility and then should have the first aid and then maybe move to another center where cardiology services are available. Which statement is correct regarding initial management of acute coronary syndrome? PCI is more definite and more durable method of reperfusion. All patients with acute coronary syndrome should undergo CABG, coronary artery bypass grafting. Thrombolytic therapy is preferred over PCI because it is cheaper and readily available. angiography is not an emergency procedure. Which you think is the correct statement regarding initial management of acute coronary syndrome? PCI is more definite and more durable method of reperfusion. So in acute coronary syndrome, our aim is to reperfuse the jeopardized myocardium. We could do it with PCI, and we could also use thrombolytic agents. Of course, the advantage of these thrombolytic agents are that they are available everywhere, and they can be done even in remote hospital. But if angioplasty is available, if the facility for coronary angiography and PCI is available, that definitely has better response and more durable response, provided it is available. Which of the following medicines is not typically advised at the time of discharge after recovery from acute coronary syndrome? In some cases, maybe it is indicated, but typically in somebody who has recovered from acute coronary syndrome with or without PCI, and which of the following medicine is typically not part of routine prescription? Digitalis, aspirin, clopidogrel, statins, or beta block, which is typically not a part of standard treatment. Digitalis. Digitalis is used to be very popular drug and was actually never indicated in ischemic heart disease. It is the treatment for heart failure and still used in some selected cases, but not always. It is certainly not the routine treatment after PCI, whereas aspirin and clopidogrel both are typically prescribed because these days we start on dual antiplatelet therapy, and statins are always indicated even if somebody has baseline lipid within the normal range. After acute coronary syndrome, we want to lower their cholesterol further down. Beta blockers are also very useful after acute myocardial infarction, for example. If beta blockers are given for about 1 year, they may reduce the chances of sudden death. So beta blockers have also become the standard treatment after acute myocardial infarction. So that was all. This is Professor Azizur Rahman, and from Medurstand. I really look forward to see you in my next video. Thank you very much for joining me here.